welcome to tonight's program titled, Can You Compete in Early Cancer Detection? A CME Jeopardy activity. We're honored to have participants from across the country here this evening, not only in this room, but also viewing online. This program is supported by an independent grant from Grail. Everyone in the live audience should have the following items at their place setting: a card with a QR code, which will give you access to program slides, accreditation and disclosure information, as well as a library of valuable clinical resources. A two-sided program evaluation form. Please be sure to complete and return this form to the ushers at the conclusion of this program in order to receive credit. A keypad to respond to polling questions throughout the program. Your responses are anonymous and very important to the educational outcomes of this program. For everyone else joining us at home online, all this information is located on the right side of your screen under the Handouts tab. The evaluation will automatically open in your web browser following the conclusion of the program. For our live audience, if you would like to ask a question during the presentation, please write it down on the question card located in front of you. Ushers will be collecting them throughout the program. If you are at home, you can submit questions through the Q&A box on the right side of your screen. Now, let's give a warm welcome to tonight's presenters. Dr. Mylynda Massart, Dr. Richard Whittington, and Dr. Charles Vega. Enjoy the program.
Awesome. Okay, great. Well, it is wonderful to be here. It means a lot that you came out tonight. I know that you probably attended the conference today. You've had a busy day, so it means a lot that you're with us, and we're going to try to give you some great information. I just want to say hi to everybody who's watching online as well. And for you, we have a special treat. We've arranged this is beta testing, but we do have a technology. We have a wall up here with screens on it, and we're able to turn on all of your cameras and microphones remotely. And we're going to do that in 3, 2, 1. No, we're not going to do that. That doesn't exist. But I just want to know if anybody threw your tablets out there, I would be like, just throw it out the window. All right, so let's. So there's our disclosures. Importantly, if you see the little red string slide, you want to pay attention to it. I'll try to point those out as we go. And so what are our learning objectives tonight? We're going to start with a little bit of didactics, but then we're going to move into a fun Jeopardy game. Don't worry, the pom-poms will be used. They're not there just there for fun. So we're going to be talking about cancer screening. I'm a family physician at UC Irvine. I work in the biggest safety net clinic in our county, and I do cancer screening every day. I know something about how beneficial it is, but also its limitations are stark to me on a regular basis as well. And we're going to move into cell-free DNA and using these liquid biopsies. How is it different? What is effective with it? And then we're going to go into the data. Do these tests work? Because now we actually have good data from prospective studies that show what are the benefits and potentially some of the limitations of these tests. And then finally, Mylynda's going to bring it home by talking how do we actually use these things in our practice. Okay, so here we go. So we have a few questions, actually a number of questions to start, so get those keypads out. And it feels like I'm ringing. I don't know if you need me to do anything with, you want me to lower my mic? No? Sounds okay to you? Good. All right. Approximately how many patients, 50 years, at least 50 years old, do you see each week? None. 1 to 10, 11 to 20, 21 to 30, over 30. I don't manage patients 50 years old. I'm biased. Mark the answers now. No, you're not biased. Mark the answers now. All right. We're just going to kind of go through these. We'll give you a second. Yeah, cool. We get an adequate number of responses. 2, how familiar are you with the currently available multi-cancer early detection or MCED test for adults? Not at all, slightly, neutral, somewhat, or very familiar. Alrighty. 3. All right, let's dig in a little bit more now. With approximately what percentage of your patients at least 50 years of age do you currently discuss the possibility of administering MCED tests? None, 25%, 50%, 75%, 100%, or I do not manage patients. I swear I don't manage patients 50 years old. My Why do you keep bothering me about this? Knowledge questions now. Here we go. What percentage of diagnosed cancers in 2021 were not detectable through current USPSTF guideline recommended screening modalities? 25%, 57%, 68%, or 83%? United States Preventive Services Task Force. But I bet all you knew that. Please mark your answers. I will elaborate on acronyms I can pronounce that aren't too difficult. That's one of them. Sometimes you see like something is funny. All right. In counseling a patient about a positive cancer-detected result from a Gallery test, you explain to her that according to the Gallery real-world data presented by Westgate et al. At the American Society of Clinical Oncology, or ASCO, 2023 annual meeting, the cancer signal of origin prediction is blank accurate, 25%, 46%, 67%, 91%. So how often was that cancer signal detected correctly linked with its site, its anatomic site of origin? I bet if Dr. Westgate was here, he could help you. All right, you receive MCED results for a 57-year-old woman with cancer signal detected, predicted ovarian origin. Your next step would be to refer the patient for blood work and how about an abdominal pelvic exam with ultrasound, CT of neck, chest, abdomen, pelvis with intravenous contrast, a magnetic resonance imaging of neck, chest, abdomen, and pelvis, or CA-125, and refer on to gynecology. Please mark your answers. Smooth, dulcimer tones of Chicago. Julia, 49-year-old woman whose older sister was diagnosed with breast cancer at age 41 years. Julia is negative for all hereditary breast cancer genetic tests, BRCA1, BRCA2, and up to date on her current mammography screening. Due to increased risk, she also undergoes annual breast magnetic resonance imaging with contrast. Should you recommend an MCED for Julia at this time? No, she is currently compliant with all recommended screening and testing modalities. Or two, no, she does not meet the minimum recommended age for screening. No, because her genetic test results are negative. Or yes, because her high-risk status and possibly that the cancer may not be detected by conventional mammography and or MRI. Please mark your answers. I'm not sure this will help us today. We better need to pep it up a bit. Mason, make it so. All right, addressing the unmet needs of cancer. So cancer, as you saw from the screen, if you're watching some of the scroll up there, it's still number 2 leading cause of death in the United States. One thing that's really impressive to me, your lifetime risk of cancer is 40%. 4 out of 10 folks will develop cancer. And yet, about 2/3 of folks who are adults are not up to date on their routine screening. It's something I know very well from my clinic, and I think we all have some experience in that area. I get untoward satisfaction when I get to check up to date on all health screening, and that's unfortunately a rare occurrence even in my practice where I really pay a lot of attention to it. Yet it's so important to do so, because I'm going to actually direct your attention to the green part of this table. When you diagnose cancer earlier, the survival is much, much better. Just about any cancer, by the time it's stage 4 and you have distant spread, the risk of mortality due to that cancer goes way up. Of course, age is a risk factor for cancer mortality as well. Many times that's due to comorbid conditions that the patients may have. And then there is important racial and ethnic disparities in terms of cancer survival as well. But who's not being screened? It's people of color, it's people from areas where they don't have access to quality care. And so I actually think MCEDs could really be a game changer, and that's the community I work with. I think MCEDs could really be a game changer for those communities, because we're moving out from a one-at-a-time approach. Let's go check you for breast cancer. Then we're going to recommend a colorectal cancer test. Then we are going to think about prostate cancer screening, into a test that can test for many different cancers, over 50 all at once. And so overall, while the 5-year survival for cancer is fair and gotten better at 68%, I'm going to talk about how screening makes a difference shortly. We could do better. We're missing a lot of folks. And these are recommendations you're probably familiar with. I'm just going to touch on them because we don't have a lot of time and I want to get to our game that I know you're itching to play. But just to call out for breast cancer screening, the new guidelines are in a draft stage from the USPSTF say down to age 40 to 74 years. Cervical cancer, great example of a public health campaign that worked, especially for those low-income communities of color where cervical cancer is much higher. Now we see much lower rates. Colorectal cancer, I was surprised that for folks around 65, we see good coverage. 2/3 of actually up to date on their colorectal cancer screen. That's because I've ordered 12 FIT tests on one patient and still like, it's going to come back this time. Oh, baby. And that's where you pull back and you have a discussion. Maybe, what's the issue here? Let's try to work on this. And lung and prostate cancer too. Those are the big 5. These are the ones we should be screening for. But it means we're missing out and not screening for many other types of cancer, important ones like ovarian, pancreatic, testicular, and thyroid. And that's 11% of all cancers and a disproportionate number of cancer deaths, particularly related to pancreatic and ovarian cancer, which have that higher mortality rate because they're often grow undetected. When you detect cancer early with one of those big 5, you're able to make a positive difference. And so these are national rates, and we see rates of mortality decreasing because we're screening for these cancers. We're detecting them at an earlier stage, and therefore better outcomes ensue. And yet, only 25% of all cancers are actually detected via screening, so a quarter. And 18% are actually, of those big 5, become symptomatic. So usually by that time they're progressed and they're more advanced, less likely to respond to treatment. And not just thinking about mortality here. I think that's our kind of the core of the realm when we think about cancer outcomes. But it's also morbidity. So many of my patients with advanced cancer got radiation treatment, got multiple surgeries, had chemo and complications. And unfortunately, that led to disability, poor quality of life. And even though the cancer is in remission technically, it left an effect on a patient that's really profound. And so 57% of cancers have no preventive screening tests. And you can see that we kind of have an approach, particularly that doesn't always nail it in terms of specificity, which we're going to go in statistics pretty soon. You can see that 1/3 of cancers found in the National Lung Screening Trial designed smokers who are at risk for lung cancer were not lung cancer. And we're all very familiar, I think, with lung CT and finding incidentalomas. It's kind of the bane of my practice. Takes up a lot of time. And can be really onerous and very stressful for the patients as well. So we want to reduce the amount of false positive findings and try to help our patients to understand, okay, this cancer actually, when you have a signal detected, as we'll talk about the MCEDs in a minute, you're much more likely to actually have a true cancer. This is modeling data looking at these liquid biopsies, MCEDs, in addition to our usual care, if we augmented and started doing these MCEDs on a regular screening interval. So this is not real-world data. But through modeling, you can see that biannual MCED screening can reduce cancer prevalence or incidence by 17%. If you're doing it annually, you get even more cancers. That kind of makes sense. And so overall, you can see that this is going to be a game changer. If you broadly start applying MCEDs, we are going to be detecting a lot more cancers, a lot more different types of cancer that heretofore we don't have a ton of experience with treating early ovarian, early pancreatic cancer. And we're going to need a lot more surgeons. We're going to need a lot more oncologists. And so, but at the end of the day, you're going to really help a lot of people. A lot of people will live longer, they'll live better because they had their cancer detected early. So this is another model that looks at the application of MCEDs for folks who are undergoing their regular routine cancer screening. And as we're going to reiterate later on in this program, we still screen. Even if your patients are using an MCED regularly, we still want to apply routine breast cancer screening, routine cervical cancer screening. The big 5 still should be screened for as recommended by USPSTF. But if you're able to add an MCED, say, to a woman undergoing cervical cancer screening, you increase the likelihood that you're going to find a cancer by 25 times. If you add it to a colorectal cancer screen, you get 12 more types of cancer. And that's not just colorectal cancer. This could be, a blood-borne cancer. It could be liver cancer. It could be thyroid cancer. And then with breast, similarly. Breast is more common, so you don't see that big a bump up in terms of extra number of cancers detected, but still a 3 times increase. So all modeling data, but very intriguing, and shows the public health potential of these tests. And one of the questions, we'll actually get into the cost and economics, but if you can detect more cancers early, where does cancer become most expensive? Where is a lot of those dollars go to? End-stage treatment, right? Advanced cancer treatment. That's where the real cost of cancer care comes. Not so much from screening. Screening is relatively cheap. And so therefore, if you start expanding the number of cancers found, and you find these cancers early, less advanced cancer, and you can see the cost of screening goes from $89,000 per cancer found down to $7,000. Just a really remarkable reduction, and shows again the power and the value of these MCEDs, which are not, this isn't science fiction. This is not in the future. This is something that we have right now, and that's why I'm going to hand this off to Richard. Oh, thank you. We'll relay it. This is a reminder. Please fill out your cards as you go through for questions. And yeah, Richard, please take it away.
Okay, so let's move into the actual science of how these tests work. The idea that we've all done and used is one test, one screen. As Charles recommended, we do a colonoscopy for colon cancer, mammography for breast cancer. It's something we wrap our heads around every day and try to get our patients to do it, hopefully successfully most of the time. But the idea of a liquid biopsy is something different. The idea is that it's non-invasive versus our invasive approach of doing a biopsy. It's basically just blood tests, drawing off blood and using what's in the blood to tell us what's going on. It can characterize across all tumor sizes and values. It's looking specifically for where the cancer comes from and whether or not you have the cancer active within you. And what's really intriguing about it is that potentially, because of the amount in the bloodstream or the decreasing amount in the bloodstream, this could be actually used in the future to judge the effectiveness of our treatments of the cancer. There's a lot of things that are just coming into light on multi-cancer early detection that are actually going to exponentially change the way we're doing things. So how does it get there? Turns out that cancer, even in earliest stages, stage 1, is releasing cell-free DNA into our bloodstream. Actually, just even the amount of general cell-free DNA in our blood can predict cancer. We all have some, even if you're completely healthy. But if you have a lot more, that actually just predicts cancer by itself. And how does it get there? Apoptosis being broken down, necrosis of the actual tissue, actual secretion by the cancer cells, puts it into the bloodstream. I don't want to go over all the detail on the right, but basically all of those little molecules and DNA changes are things that we can assay and look for to determine whether or not you actually have some cancer going on. The most exciting part to date is this idea of DNA methylation. So turns out, and this is not like data or science fiction, as you said, right, in the last year or two. This is 30 years of data working on DNA and methylation, multiple study after study after study. It took machine learning and AI to be able to look at 100,000 things in the blood in a short period of time. But the science of what we're looking for has been there quite a while. It turns out that every specific tissue in our body has a specific methylation pattern. So your esophagus has a specific methylation pattern, liver, pancreas, and so forth. So the cell-free DNA, if it's methylated a specific way, you have a fingerprint of where it's coming from. And then the way oncogenesis works is that, in many ways, one way oncogenesis works is you subtract methylation. And as you take methylation groups, methyl groups off of your molecule, it turns on oncogenes. So if you have a fingerprint of where it's coming from, yet it's missing some of its site of methylation, that's how you get pancreatic cancer. It's very interesting, and the studies are actually coming to light as we speak. There's prospective studies out, as we've said. I'm going to get into some of those. There's like 6 or 7 that are around the corner in the next year or two. I think it's very important to say right now, none of the tests that are coming to light, including the one that's commercially available, is FDA approved. There's only one prospective study out, which I'm going to talk about, Pathfinder. There's just been actually a new one released in National Health Services in London, but that's more diagnostic. I don't want to get into that too much tonight. But there are multiple coming out, and this hopefully will give us the repetitive data that we're all seeing on all these tests that would say this is valuable to all of our patients, and hopefully that insurance will cover it so that our poorest of the poor and the people who really could benefit because they have the most trouble getting their routine screening can get these tests. Moment to take a pause here to say multi-cancer early detection is looking for the changes in the blood that go along with active cancer. Whereas like checking for a BRCA gene is looking for genetic risk. So genetic workups are for risk calculation, which are very important. And this is truly a screening test looking for cancer. And the two do not meet. Okay, I hope you guys are not eating too much because we're going to talk math.
This is the dangerous part of the talk.
This is the dangerous part where I could easily screw it up.
No.
It's important to know math, though, for this because we're talking about positive predictive values, false positive rates, true positive rates, and when you're going to be explaining things to patients, as we already do with just routinely with a mammogram, the low likelihood it's actually going to be cancer. These are things that just flow off our lips because we've been doing them forever. This is going to take a few years for all of us to get comfortable as these come to bear with how to introduce it and what are the downfalls, pitfalls, and what are the advantages. So sensitivity, once again, is the ability to catch a true positive test. Specificity, the ability to catch a true negative test. We don't use those much, but they're the foundation of all the other statistics. Okay, so the ones we do use. Positive predictive value. So that's your true positive rate over all of the positives, right? So that would be the true positives and the false positives. And then your negative predictive value would be the exact reverse, right? True negatives versus the true negatives plus the false negatives. I hate just talking math. I'm much better visually. I bring this slide up because I think this is one we can put our lips around and understand, hands around it. Colorectal. Look at the left. Let's look at the left side there. Go to colorectal. 167 patients need to be screened to find a colorectal cancer, and we do that one. We're all in on that. But if you move to the left of it, which is a lower incidence on the lower axis in the population, you'd have to screen 500 for pancreas, 588 for liver, 833 for stomach, 1,000 for esophagus in low-risk populations. I'm not talking about high-risk populations, I'm talking about low-risk. Why don't we do those? Well, we don't do those because it's expensive, it's invasive, and the bang for the buck is just not there. Now, if you move just to the right of the colorectal one there, you see that green dot. I think that brings this home mostly. If we had a test, blood test, even any sort of invasive screen, whatever, but if we had a test that would catch all of the colorectal cancers, we would only need to screen 83 people. That's the power of aggregation. Put it all together in one test, and all of a sudden you don't need to screen as many. And if we were so fortunate to have a 100% sensitive test, all true positives, that would catch the 3% incidence rate of cancer in our country over the age of 50, we would only need to screen 33 people to find a cancer. Obviously, that would be the true holy grail, right? Having a test that caught everything and never missed anything and never told us anything false. But that's the goal. So let me swing to the screen on the graph on the right, because that kind of takes that data and pulls it forward. If your prevalence rate is 3%, which it is, that's the prevalence rate of cancer after the age of 50, and you had a highly specific test, 99% plus, then you're going to be able to get a positive predictive value with a test like this of about 60 to 70%. That's as good as it's ever going to get because it's such a low incidence. So even if you had 1 out of every 300 people to have a false positive test, if you only have a 3% incidence, you're not going to catch many cancers. And so then when you put those over each other, for your positive predictive value, you realize your positive predictive value is only going to be about 60 to 70%, and that's if you're perfect. So, what's out there now? Cell-free DNA-based multi-cancer early detection assays that have received FDA breakthrough device designation. We're all familiar with that term with COVID and our ability to treat things and give vaccines and things, and so there are 3 out there now that have that capacity. Gallery, which was the first. Gallery looks for pretty much every cancer we could possibly have. Multi-cancer early detection is not equally sensitive for every cancer. Ovarian, pancreas, it's fantastic. It's over 90%. Breast cancer, 33%. So not so great there. Another reason why we have to keep doing our routine screens. This is not going to supplant those. I wish it would. I wish we could just draw blood, forget about screening everything else, save all you guys a bunch of time, let you all be heroes. But unfortunately, this is going to be an add-on. And so then the other 2, and that's looking at methylation DNA. The other 2 are looking at methylation DNA too. They're also looking at some protein biomarkers, and they're a much smaller subset of cancers. They're looking at like the top 60% of cancers that evolve, and they're looking at the ones that have the higher sensitivity. The idea is maybe not screen everything, but give us the best of both worlds with a very high specificity and a very high sensitivity and the best positive predictive value as possible. I'm going to get into now where we're at. Okay, so first, specificity, false positives. They are fantastic. This is real-world data. This is that Pathfinder there is a prospective double-blinded study. 6,000 people across the country. I was involved in that study as a site lead. 99.5. That means 1 out of every 200 people is going to have a false positive test. Now, I don't like any false positive tests, but it's what we see every day in our routine screening. And if you look at their sensitivity range, they're catching about half. Is it great? No, I wish it was better. But 50% of a large number is still a large number of new cancer diagnoses, right? I mean, sure, we're not catching them all, but you're catching 50% more. So all of that is exciting. And you can see that over C on the bottom, because they decreased the number of cancers they were screening for and got rid of the lower sensitivity cancers. They got their sensitivity range up to 80%. So, positive predictive value of this test, okay? We're talking the Pathfinder study. We don't have it on some of the newer release ones, but I can talk about Gallery on that 50-channel cancer test. It's about 44% positive predictive value. So that means about 1 out of every 2 patients you're going to be explaining a false positive. That makes me pause. I don't really like the idea of every other patient that I have a positive test, I'm going to have to explain a false positive. Remember, the incidence is low, so that means about 200 tests come back negative, and they're negative, okay? The specificity of the thing is 99.5. So truly, the people that test negative, almost all of them are true negatives. The ones that come back positive, which would be a couple out of 200 people, about half, a little less than half, are going to be true positives. And then there's the bonus. This is something we've never had with any screening before. The idea of cancer signal of origin identification. Not only do you get told this patient probably has cancer, you get told exactly in the body where it's at. And it's right most of the time. The studies are showing in the mid-80s or above. 58,000 people have now had the Gallery test in the real world. They've had paid for it, had their insurance cover it. There are some insurances already paying for it. But 53,000 people, and the accuracy of the point of origin was 91%, which means only 9% of people didn't have the test point them in the right direction. So, what screws the test up? Positive HPV. Positive HPV cancers happen in a lot of parts of the body, and so we get led one direction and it throws us a different direction. That's one reason. And then I actually had a patient that I actually saw this on myself, was the patient didn't have cancer, they had a monoclonal gammopathy. Obviously, a small percentage of those patients will come back and eventually develop cancer, but it's not cancer today, and this thing picks that up really well. But I want to stop here, and on this slide specifically, it goes back to what we do. Okay, so as we're all hemming and hawing about maybe I've got to explain 1 out of every 2 patients with a positive cancer test that doesn't really have cancer, look at the breast data there. Positive predictive value of a diagnostic mammogram, 4.4%. Okay? Look at the low-dose CT on the specificity, 97.7 to 100%. That is exactly equal to what this blood test does as far as specificity. I think that those are things that just are like, grab your attention just a bit. There's lots of studies going on. I guess I just bring up this slide to just momentarily say, hey, we got more data coming. Hopefully you guys all learned the basics tonight, kind of get an idea of what is en route, so to speak, and how you may or may not use this test. But we're going to have a lot more data backing up or refuting what we already know.
So, Richard, can I ask you a question?
Sure.
So just because, before we get started, first of all, make sure you're putting in your questions. We'll come around with cards again. So right there. So just put your hand up and grab a card and write it down. So just putting in perspective that, that positive predictive value MCEDs 44% versus, all the mammograms that come back positive, the vast majority aren't cancer, the PSAs that come back positive and aren't cancer. I mean, we're kind of used to discussing those kinds of results. And remember, this is all screening. They're all screening tests. They're not diagnostic. Do you think that's going to be a stretch or has it been a stretch for you? Because in your practice, you've used these more.
Well,
so I'd look to your experience.
Yeah, when Pathfinder was started, all of my partners and everybody I had involved, we all referred any positive test directly to oncology because there was no prospective study yet. Nobody was interested in kind of, talking
being
about the unknown, right?
Yeah.
Being the first. So we had oncology involved. And since then, we've had our tests come back, positive, negative. We all are getting a better understanding of it. I think it's really scary for all of us. I mean, it's new, right? I mean, well, think of yourself coming out of medical school and learning your colonoscopy thing and having your first conversation with a patient about screening. It's your first conversation. But I do think that all of us are adept at conversation and communication, and as we learn the data ourselves, it will become more locked in our brains. It will not just be new. It will not just be, oh my goodness, and I think we'll quickly get over it because, like I said, we have false positive conversations all the time. We just don't even realize it anymore. So yes, I think it'll be scary. Yes, there's going to be a learning curve, and I would think it'll be that after 2 or 3 conversations, we'll get through that.
Yeah, and this is actually a really good segue to Mylynda's section, so go for it.
I know, but I just want you to see this. I'm so short that I'm on a riser, so I can see over the podium.
It's the power of MCEDs.
It's making me feel very tall and very empowered tonight. So I'm going to wake you all up a little bit. Instead of doing a digital poll, I'm going to have an old-fashioned poll with a raise of hands. How many of you, like myself, have had patients come into your office and say, Doc, how come you just can't give me a blood test to look for all cancer, right? Me too. So how exciting is it that in 2023, we can actually now say that technology exists? We actually have the ability to order such a test, which is completely transformational to how we're going to practice medicine in the future. And so I'm going to take us into a little bit about implementation into the primary care practice and some of my experience. So what are some of the challenges associated with integrating multi-cancer early detection into a routine primary care practice at this time? The biggest challenge is, of course, we don't have national guidelines yet, right? And without national guidelines, it's a little uncertain. Guidelines take a long time, sometimes on average up to 10 years to actually collect enough data to be published. But that does not mean that there isn't excellent technology out there that we should be considering. And it doesn't mean that your patients aren't going to show up and start asking about this because they're reading about it in the New York Times or in Time magazine. So the biggest takeaway point I want you to take tonight is that these multi-cancer early detection tests are meant to complement our current single organ USPSTF screening guidelines, right? They are not intended to replace them. They are meant to complement them. Those are truly our gold standards. This is a newer technology, and although the science is excellent, it does not replace our current single organ screening, as was mentioned, because of the overall sensitivity and specificity is very high in those gold standard single organ screening. But this is allowing us to screen for many, many more cancers that we just have not had the ability to do so before, including all the ones that we've all been most concerned about, right? Ovarian cancer, pancreatic cancer, that we often don't see in our patients until very late stage, and our patients don't survive that. And this has the potential to even capture it as early as stage 1 or stage 2, which is tremendously exciting, I think, for us in primary care, and equally nerve-wracking for our oncology fellows who actually don't yet totally know how to treat stage 1 and stage 2 ovarian and pancreatic cancer. So there's going to be a bit of a learning curve on that side as well. So another thing that we need to think about is, what are the recommendations, since there are no guidelines? What are the recommendations on who this screening test should be offered to? So it's truly anyone who meets a high-risk diagnosis, and there are many ways that folks meet a high-risk diagnosis. First of all, it's just by age. So all of us in the room, including myself, over the age of 50, are high risk just by age alone. And that's just because the incidence of cancer dramatically increases after the age of 50, right? And then if someone's had a family or a personal history of cancer, that can increase their risk. If they had a childhood cancer that they survived to adulthood, we know that based on that prior treatment and pre-existing condition, they are at higher risk for cancer. If they have a known hereditary cancer mutation, right, like Lynch syndrome or one of the BRCA mutations, they're at higher risk for developing cancer. And then many, many other risk factors, which you can see outlined on the other side, which are mostly environmental. We all know that there are predisposed risks and then many, many environmental exposures that lead to manifesting those risks. Who is not eligible for this screening? So currently, anyone under the age of 21 is not eligible for the screening at this time. Pregnant patients are not eligible, although just a side note, it's very interesting. This cell-free DNA technology was actually discovered using NIPT in pregnant women, and having this abnormal signal came back that turned out to be cancer in the mom. That's how this all came about. But now that's actually confounding if we're looking for cancer in adult patients. So pregnant women are not eligible. And those who have had an active cancer treatment within the last 3 years. So those are also not good candidates for this screening test. What are some of the considerations in discussing this screening test with your patients? So I really suggest that we go back to something that we're all very good at, which is shared decision-making with our patients, right? So we review the risks and the benefits. And some of the potential advantages of the multi-cancer early detection testing is, of course, catching cancer earlier, which is the whole goal, including in asymptomatic patients, which is a fundamental in screening. Trials have demonstrated improved efficacy of testing with increased positive predictive values and decreased number needed to screen. And that we are able to screen for cancers that we haven't been able to screen for with our previous single organ screening modalities. I also think there's a great advantage in terms of thinking about access and equity in the future when we're talking about a point of care blood test that can be drawn right in the office. How much easier would it be to successfully achieve that than to have our patients take time off of work and transportation to get to each of those individual types of cancer screens, which have made it really challenging and is why we haven't been all that successful.
Right.
And then some of the disadvantages, right? Because informed consent, it's important to understand the risks and the disadvantages. So it's currently not covered by most insurance. There are a couple commercial plans and employee or government-sponsored plans, but on the whole, not yet covered. No cancer signal detected result does not mean there's no cancer. It is a screening test. So like all other screening tests, there are false positives, right? And there are false negatives. So it's always important that patients understand that. And then things like possible harm if you do have a false positive and we have to undergo a diagnostic evaluation, just again, like mammography, 1 out of 15 positives is actually only a true positive. So 14 of those 15 may be undergoing more diagnostic imaging, invasive biopsies, which are painful and costly. And that's a risk for harm. But that is one of the consequences of all of our screening tests. This question is one I get a lot when I talk about multi-cancer early detection. How often should we be testing if there's no guideline to tell us that answer yet? And this is truly personalized medicine. So really thinking about the individual patient sitting in front of us and what is their pretest probability, right? If they have a high pretest probability, maybe they have a known hereditary cancer mutation, or they're a cancer survivor now 5 years out from their treatment, or this massive family history or huge exposure risk, we might think about that repeating that testing interval more quickly, more soon, right? Like maybe twice a year in that population. And if that patient sitting in front of you has a very low pretest probability, they're very, very healthy, they're exercising, they're following all their guidelines, no family history, no exposure risk that we're aware of, we might think about stretching out that screening interval to maybe every 2 years and maybe even 3 years in the future. We just don't have enough data yet to really say. So I really encourage everyone to think about this on an individual patient level. And as I mentioned before, I think the biggest thing that everyone is facing as a challenge is that it is not yet routinely covered by insurance. It is reimbursed by flexible medical spending accounts, and there are a couple of insurances popping up around the country that have started covering the test, but until we really reach a level of clinical utility data that is decided nationally by our guidelines, it is unlikely that it's going to be routinely adopted. There's a large effort to push this through because, again, you know, historically, lots of randomized controlled trials can take 10, even 20 years to get that level of data. That's a lot of people with cancer that we would be missing if we waited that long to implement this. So there's a big push in government, and there's been several bills introduced, not yet passed. There's also been a lot of federal funding that has been put to trying to advance that science and really push it forward so that we can achieve that utility data and hopefully achieve coverage in the near future. So how does this actually work? So currently, while we saw that there are actually many multi-cancer early detection liquid biopsies in the research space right now, there's only one that's clinically available for ordering, which is called the Gallery test. And to order this, you can use a paper requisition, you can register on their online portal. It's quite easy. You can train staff to actually complete all that paperwork for you. Kits can be in the office for that point of care blood draw. It's 2 vials of blood. I actually practice still predominantly mostly telemedicine, and so I can order kits to be shipped right to the patient's home. They can schedule a blood draw at their local laboratory. And then once that kit is shipped back to the company, it takes about 10 days for the results to come back. For me, I use the portal, so results come back to me in that portal with an email notification that there's a new result. And then other people can set that up to also still work on faxes. So as you mentioned earlier, at any given moment in time, you know, 98% of your patients are going to come back with no cancer signal detected. So if you do decide to adopt this, don't get too nervous. 98% of the patients are going to come back with no cancer signal detected. But about 1 to 2% of the time, a positive cancer signal detected result is going to come back. With a positive predictive value of 44%, that then means that patient has about a 1 in 2 chance at that moment in time of actually having cancer. So with that, we're going to proceed to a diagnostic evaluation. Because of the cancer signal of origin, those guidelines are also provided. So national guidelines for working that cancer up will come back in the positive cancer signal detected report. So it'll actually advise you on what to do. So you can go ahead and follow through with that diagnostic evaluation. Of course, it is never wrong as well to call a local oncology friend and to also get assistance with especially those first few cases, which might be a little bit nerve-wracking as we're taking on this new technology. So this is some of those examples of the recommended diagnostic evaluation. If that test comes back cancer signal detected, it will have the first and possibly a second cancer signal of origin identified. If it's colorectal, for example, highlighted in the yellow, you're going to proceed to a colonoscopy. So you're going to call your GI friend, right, and get your patient in quickly for a colonoscopy. If it comes back cancer signal detected ovarian, you're going to order an abdominal pelvic exam, ultrasound, and these are things that we know what to do. We do these all the time. These are not new or strange. And if it comes back breast, then we're going to do diagnostic mammography with ultrasound. And if they just had a mammogram in the last 3 months that was negative, we're going to proceed to MRI because it wasn't detected on the mammogram. So we're going to up the ante on that. This is an example of a case study that was published for a larger rollout of multi-cancer early detection across a US-based health system. And it was very simple. They assessed patient eligibility, so just like I talked about, does the patient meet any of these high-risk criteria? If they did, they were invited to participate. They registered online, and then the patients were ordered pre-test counseling in this particular scenario and how they set this up at their institution. And then after pre-test counseling, they had multi-cancer early detection testing that was done. The lab was drawn and sent off to the company, and the results came back in typically 10 days, up to 2 weeks. And then those results were returned back to this multi-cancer early detection screening team, and results were then delivered back to the patients. As I mentioned, 98% of the patients are going to come back with that no cancer signal detected, but those 1% to 2% that come back with cancer signal detected, this team developed a protocol to notify the patient within 24 hours. And then they were scheduled for diagnostic testing based on that cancer signal of origin. And what this paper published was that the median time from cancer signal detected to result, it took 22.8 hours on average to notify the patient that there was a positive result after it was returned. The initial diagnostic evaluation on average took 3.1 days to get them in to start that diagnostic evaluation. And there was a resolution with a cancer diagnosis in 6 patients out of 925, so 6 positives out of 925 that were tested in 8.7 days. So very, very quickly in this implementation, they were identifying the positive screens, and then they were getting them in for their diagnostic imaging, and then they were finding that cancer. And then initiation of treatment for the cancer on average was within 33 days. So in summary, I'm sure you're tired of hearing us talk, and there might be some fun activities coming up next. But in summary, first, multi-cancer early detection can successfully detect a cancer signal and its point of origin in the body. Multi-cancer early detection tests are intended to complement other screening strategies, not to be used instead of current cancer screening methods. Statistical modeling indicates that adding multi-cancer early detection testing to usual screening protocols could result in 3 times as many cancers diagnosed compared with our current routine screening alone, and 17% fewer cancer deaths per year. Currently, lack of guidelines and insurance coverage are significant barriers to overcome, but we, I think all of us on this stage can agree, are really optimistic and excited about this reaching the state where we can offer it to all of our patients who are eligible.
It's absolutely a game changer. Let me just ask you a quick question. So the MCED test itself often not covered by insurance, but what if a patient gets an MCED and needs a colo, needs to have an MRI, needs an onc referral?
Yeah.
Is that covered, generally speaking, in your experience?
Yeah, it absolutely is so far in our experience in the providers and groups that are communicating across the country. And that's, again, with that 44% positive predictive value. Mm-hmm. You know, that 1 in 2 chance almost that at that time that patient has cancer, insurance is covering the diagnostic evaluation. Just like they're covering diagnostic evaluation for a 4.4% positive predictive value in mammograms.
That's a good way to put it.
Yeah. So but that's a really important question and really important to know that yes, the diagnostic evaluations are being covered. So this is just a reminder. There are these references on your table. There's also a card with a QR code at your table. And if you scan the QR code, you can again access these references as well as additional resources, and just to be aware of that.
All right. You can say, the card's handy, you're saying, go get screened for cancer. Wave it at them. Let's play some Jeopardy. All right, let's get into it. And the pom-pom's ready, and yellow team and purple team, it's gonna get fun. All right, so you've all been assigned to a team, yellow and purple. Doctors Massart and Whittington are your team leaders. Mylynda's going to be in Team Yellow. Richard's going to be Team Purple. They are going to play a game you might have heard of called Jeopardy. And, but it's totally different from the one on the TV show. There's no legal infringements possible today. But it's exciting to do this. It'll be fun. So the team leaders will select the category and the question. Now you're going to use those devices again to answer the questions. So make sure you do so. And we'll be getting some updates on how you score as we go through rounds. And there'll be a lot of pride if you win this game. I think that's the main thing. Is the prize today is pride and excitement. All right, and knowledge. So let's get to it.
By the way, I have noticed some future family medicine doctors.
I know, Mark.
Especially on this side of the room.
Our heroes.
Can I have
you guys want to stand up?
All the ones under 18 wave their pom-poms.
Pom-pom, big.
I need you.
Nice, there it is. There's one.
For Team Yellow, okay?
That's awesome.
Woo!
They are all in Team Yellow.
I know, I got them all.
Interesting. All right.
You recruited the smart ones.
That's right.
Correct.
Correct.
Yeah. All right. So here are categories by the numbers. Is there a researcher in the house? The early bird gets the worm and the 3 Ps. Let's begin. Okay, so Richard, we did a coin flip earlier. You got to pick first category. So which category do you want and what's your value?
Oh, let's go with the early bird gets the worm for 200.
All right, let's pull it up through the magic of technology. And we'll see our question. Get your pads ready. When a tumor is detected at a localized stage, the 5-year relative survival rate is blank than when it is detected at a distant stage. 3 times higher, 5 times higher, 10 times higher, no higher. Please mark your answers now. Again, really, it's a completely different song. All right, let's see how we did. Okay, kind of a spread there. Richard, what do you think?
Well, the real answer is 3 times higher. I wish it was 10 times higher. I think other very important piece of this, though, is that the overall 5-year survival, when I saw this statistic, it was pretty impressive. The overall 5-year survival for any malignancy now is nearly 70%. It was half of that when I started as a physician back in the day.
All right, so Team Yellow gets a bump right off the bat. Here we go. Okay, so yeah, looks like they're in the lead. There you go.
Team Yellow.
All right, Mylynda, you get to choose a category. Thank you, Richard, for the explanation, by the way.
All right, Chuck. I'm going to take, is there a researcher in the house for $200?
All right, can we see in the researcher in the house for $200? And the question is, positive predictive value is an assessment of the utility of the, I see everybody's shoulders kind of slump. The last night before boards, every time it's like I get out my little boxes and I go through my biostats, like don't leave those on the table. There's going to be 4 questions on it every time. All right, positive predictive value is an assessment of the utility of the test in clinical practice reflecting, 1, percent of all positive samples that are true positives, 2, percent of all positive samples that are false positives, 3% of all negative samples that are true negatives, and 4% of all negative samples that are false negatives. Please mark your answers.
Very nice.
Yeah, yes. Look at that.
Excellent job, everyone. Positive predictive value is defined as assessment of the utility of the test in clinical practice measured as the percentage of all positive samples that are true positives. Wait, I didn't even get to explain the answer, and you guys are
we're going to shake our pom-poms.
No, they're ready to shake pom-poms. That's all we're doing now. Maybe that was the prize.
How did they win that, guys?
I know, well, yeah.
Okay.
Statistics.
I think it's rigged.
Let's not get into that. All right, so Richard, you're up.
All right. Is there a researcher in the house for 400?
All right, let's see what we got with oh, it's a whammy. Stolen your chance to answer. You had a little momentum.
Yeah.
And there it goes.
That's good for us.
That's good for you. That's right. So you lost your turn. Mylynda, you get to pick.
how about the early bird gets the worm for $400?
Okay, we can do that. Early birds gets worm, $400. Model data showed that adding an MCED to guideline-recommended screening could reduce the approximate cost per cancer found from $89,000 to blank, $45,000, $23,000, $7,000, or $2,000. Let's hear those answers. I love you guys participating. Thank you very much for doing it. See, everybody's active, makes it more interesting for everybody, and yeah, it helps a lot.
It's a little variant, though.
No, it's I couldn't see Trebek getting down to that. All right, that is pretty good.
That is good.
Excellent.
So yeah, let's go ahead with the with the description.
Taking a commanding lead over here.
Mylynda, do you want to talk about the answer at all, or I think it's just hard to know figures. It's hard to know numbers, but
It's hard to remember numbers, but yes, in the modeling data that was published by Hackshaw et al., the projected diagnostic costs, if we could add multi-cancer early detection to conventional screening, would drop it to $7,000 per screening, which is a significant cost.
Yeah, all that, and then a lot of, in terms, that's the economic cost, but the human cost, huge savings in terms of lives saved and disability lost, morbidity reduced. All right, Richard, let's see what you got.
Is there a researcher in the house for $600?
Okay, is there a researcher in the house for $600? We will take a look at the question. In counseling your patient about a positive cancer detected result from a Gallery test, you explain to her that according to the Gallery real-world data presented by Westgate et al., this is looking familiar, at the American Society of Clinical Oncology 2023 annual meeting, the cancer signal of origin, or CSO, prediction is blank accurate. 25%, 46%, 67%, 91%. What was that bonus that Richard mentioned? That's a good way to put it. So it looks like we definitely have the leader as number 4. What do you think, Richard?
It is over 90%.
Yeah.
And that's pretty
Good job,
impressive.
guys.
Not perfect, but pretty impressive. And it was with 53,000 real-world patients. So we're starting to get real numbers out there that I think we can all start to say are believable.
Yellow, got that one back.
Yellow!
Getting it back. So we have it's a pretty close dead heat with a lot of big money left on the table right now. So I don't know. Mylynda, how do you want to proceed?
I'm going to take by the numbers for 200.
All right, by numbers for 200. Free money, y'all.
Free parking!
You just win. You win that automatically.
Nice. How come they didn't offer that?
She's buying lottery tickets later at this point. She's hitting all the good ones. All right. So Richard, the turn goes to you.
Oh,
You went to the wrong team?
They gave the points to the wrong team.
I think something should be done. You lose.
I've paid him off back.
No. Here. I have an idea. Here. We're taking this away from him temporarily. You still get to choose, but I'm mad at you. Go ahead.
We need to catch up. By the numbers for 600.
That's one way. Cheating is an excellent way to catch up. All right, by numbers for 600. The draft recommendation statement released by the U.S. Preventive Service Task Force in May 23 recommends biennial screening mammography for women starting at what age? 35 years, 40 years, 45 years, or 50 years. Please mark your answers now. I like the older version. Pretty good.
Perfect.
Yeah. Excellent job, everybody. Richard, you want to go into it?
I guess I don't really want to talk about that age. Just want to reiterate that we all need to keep doing our routine screenings as multi-cancer early detection gets, as multi-cancer early detection gets implemented. We still need to do our routine screening because it will not supplant it.
All right, Yellow, you got to dig deep now. We have a new score? Ooh. Those 600s add up quick. Okay.
Especially when the points go to the wrong team.
That's true. Then they really move fast. Mylynda, let's stay constructive and positive.
I'm going to try to get some of that.
Let's move ahead. You got the next one. You got the board. You have the board.
I'm going to go for the 3 Ps at 600.
All right, 3 Ps, 600. These are positives, patients, and protocols, and it's a daily double.
Daily double. All right, we're doing this. Come on.
Can I have my pom-pom back?
No.
No. You've been bad. You received an MCED result for a 57-year-old woman with a cancer signal detected, predicted ovarian origin. Your next step would be to refer the patient for blood work and how about an abdominal pelvic exam with ultrasound, CT of neck, chest, abdomen, and pelvis with IV contrast, MRI of neck, chest, abdomen, and pelvis, or CA-125 and refer on to gynecology. What would you want to do with that cancer signal detected ovarian origin? Kind of worried about this actually doubling. All right.
Excellent.
Excellent. Yeah, that's exact. This is first step. So you can certainly consider some of those other modalities, and you may want to order them. But I think a physical exam. We're family doctors. Physical exam and low-cost imaging study is generally going to be the right answer for us. So
Definitely.
it's a good start. Oh, there it is. That's going to change things.
Yeah, daily double.
Ooh.
Oh, we got the points.
I was really worried about the math. So people are getting desperate, so they did double it. That's good. Okay, I think you get this back. Richard, what do you want now? Here.
How about buy the numbers for 400?
You've served your penance.
Your penance, yep.
Buy the numbers for 400. What percent of diagnosed cancers in 2021 were not detectable through current USPSTF guideline recommended screening modalities? 25%, 57%, 68%, or 83%? What do you think? No doubt who's having the most fun with their clicker. Love it.
But is he messing up the results?
Come on. That is unacceptable. Okay, that's it. No. You can't blame the young people for messing up your results. All right. So, Richard, what do you think?
57% of patients with cancer don't have we don't have a screening test for those 57%, which I think brings to light the importance of finding a new test like multi-cancer early detection to start grabbing that piece of the puzzle, diagnosing it early, and getting it treated fast.
Okay. Yeah, that's a
Yes,
really
we're
good
coming
point.
back.
There we go. Yeah, purple one. Okay, great. There's a lot going on here. Okay, I do know, Mylynda, it's your turn. Go ahead.
All right, I'm going big again. Let's take the early bird gets the worm for 600.
All right, I hope this works out. This is for your pom-pom, too. Choose again. That's, interesting.
Oh, but we get to go again.
I guess you do,
okay,
yeah.
well, that's kind of cool.
So you're up still, 3-piece.
All right, well, I'll take the
That's all we have
3
left.
Ps for 400.
Okay, for 400. Okay, you still want that money. All right, here we go. You are meeting a new patient for initial visit. Anne is 48 years old, has mild hypertension, a body mass index of 24.3. Anne's family history of cancer is limited to a great aunt who is diagnosed with breast cancer at age 76. Should you suggest an MCED for testing for Anne? No or yes? Ooh, this seems simple. Or is it? Don't try to trick us. Want this? Interested?
71% said no. Very, very good. So Anne is 48, so hasn't hit that age 50 criteria yet, right? She does have a family history of cancer, but it's an older cancer, right? Not an early onset cancer, so it doesn't look super, super high risk. And normal body mass index, so not high risk by BMI either. So the answer is no. She's not yet eligible for multi-cancer early detection.
So let me ask, so great job, everybody, and just kind of put a pause in. Because I have a question for both of you who have practical experience with MCEDs. Do you get folks who are, say, 30 and just turned 30 and they have zero cancer risk factors, but they've heard about this test and they just want to be protective of themselves and do everything they can and come into you and say, hey, I want an MCED. I'm willing to pay out of a pocket for it. What kind of conversation do you have with them?
Yeah, so when someone comes in with that very, very low pre-test probability because they really have no history, they're very young, they actually are at increased risk for false positives. So this is not a useful screening test for them. So that's what I explained to them, and that this is not the way to go. And then try to really get at what they're actually concerned and worried about, and kind of go through that proper discussion and pathway that's appropriate.
Yeah, that's great, because I think that could be a challenge for some of us. And it hasn't happened to me, but it's like, when somebody's, maybe that same person wants an RSV vaccine and a pneumonia vaccine, and it's like, well, not really, for streptococcal pneumonia. But I try to turn it into, okay, but here's what you can do. Is it okay if we talk about your body weight today? How is it going? I know they noticed that you were drinking, 6 drinks on the weekends, and that could be unhealthy. Tell them, is it okay to talk about that? And so just try to turn it into something more constructive that would also, fit with our guidelines-based therapy. And luckily, I love being a family physician because everything's open. There's nothing, we can't discuss with our patients. All right, let's go back to the board. And Richard, it's oh, sorry.
Yes.
Woo!
All
This
right,
is looking very suspicious,
Thanks for
though,
answering
I'm
that
just
question,
saying.
by the way. All right, so Richard, you have control of the last item.
Well, which one should I pick? I guess I'll take the 3 Ps for 200.
All right. And it fits in statistics too, potentially. Oh no, maybe different. Okay, Julia, 49-year-old woman, older sister was diagnosed with breast cancer at age 41. She's negative for all hereditary cancer genetic tests and up to date on her current mammography screening. Due to her increased risk, she also undergoes breast MRI annually with contrast. Should you recommend MCED testing for Julia at this time? No, because she's routinely compliant with all recommended screening and testing gut modalities. No, because she does not meet the minimum recommended age for screening. No, because her genetic test results are negative. Yes, because of her high-risk status and the possibility that cancer may not be detected by conventional mammography and MRI. Please mark your answers. Last one, make it count. Tighten that. What do you think, Richard?
Very good. She is 49, so she doesn't quite get to the age category, but she has a younger sister with breast cancer, so she has got a high familial risk, and this would be somebody appropriate to offer the test to. Maybe you heard a statistic I threw out before. It's only 33. The current test available, Gallery, is only 33% sensitive of catching breast cancer, but it's still additive. And these will be interesting places and difficult conversations and interesting places to potentially add the test. I would offer the patient the test here.
Yeah, it seems reasonable. It's not like between 49 and 50, there's like this sharp increase. This is a gradual increase, and 50 is a good marker, but it's just a marker, not a decision that you have to make.
And just because her hereditary cancer genetic testing was negative, not all familial cancers are known to have a gene, and so there still may be something traveling in this family that we just don't know about.
It's a little hard to talk about cancer and then whipsaw back to the game, but I think everybody kind of wants to know the result. Yes, are people interested in the results? So let's see who won this round.
Yes!
Oh, I thought for sure we were heading to Thai Town.
Everybody stand up and take a bow on this side of the room.
Oh, you all deserve.
I clap for the yellow.
As host, I'm obliged to say you're all winners.
Absolutely.
Even though only some of you are. No. Thank you for playing. That was a lot of fun. And now I think we can do a couple more post-test questions. These are important so we know how we did. How familiar are you now with the currently available MCED test for adults? Not at all familiar, slightly familiar, neutral, somewhat familiar, or very familiar?
Okay.
Oh, that's an intimidating
We're
stat.
going to look through some of these.
Yes, I gladly will.
Yeah, just divvy it up. Thank you. Oops. So, good. And yeah, that's a big improvement. Excellent. I'm glad. This is new for a lot of us. It was new for me. It doesn't seem that long ago, but it's certainly going to be part of the present and our future. So thanks again for being here tonight. With approximately what percentage of patients 50 years old will you now discuss the possibility of administering MCEDs? None, 25%, 50%, 75%, 100%, and you know what number 6 says. Oh, I got the same question. Did you get overdiagnosing question? I got 2. Okay, so, that was fast. Okay, yeah, it's because we're doing pre and post. Okay, so none, and we start to see, yeah, some changes. I think that those limitations are quite real for many of us in practice, and so, but it's good to see that some of you are going to start taking that step, and patients may very well come in. How many of you actually, let's do the old-fashioned poll again, how many of you actually have had patients come in and ask about MCEDs independently without necessarily being prompted? Yeah, so, and I bet next year, that many more of you will have a hand raised. So this gives you something to work with. I'm going to look through these real fast, but who wants? You guys can just go first. We have a good amount of time for all questions.
I'm going to grab one real quick right here. I think it was a really good question. Do you anticipate patients will feel falsely reassured by a negative test and skip routine single organ screening recommendations? Absolutely yes, unfortunately. I have already had patients telling me, well, I've had that blood test. It says I don't have any cancer. Why am I going to do this and this and this? And that's unfortunately why we're going deep into some of these math statements, right, about the sensitivities of the different things, because by no means is multi-cancer early detection going to have a sensitivity of 100%. It's at best 50%. Right now. So you have to keep working with patients and say, yes, that's additive, but you definitely need the other screenings. And then the next one, unfortunately, I haven't heard of any yet, but they said, are there any patient assistant programs for cost assistance? And I don't know of any yet.
So there are a couple of folks who have submitted foundation grants around the country. Because obviously this is an equity issue, and I think that's really important to many of us.
Alrighty, sounds good.
Yeah, emerging technologies like this, if they're not covered by Medicaid and Medicare, then some of our most vulnerable patients and some who are at the highest risk for late-stage diagnosis and cancer disparities are not having access, and I think that's something that has to be addressed. So a couple of my colleagues across the country have submitted equity grants through local funding, foundational funding. So that's the only programs that I'm aware of, but I am not aware of any patient assistance application necessarily through the companies themselves. I have a question here, if I can. Yeah, I think it kind of is similar to what you were answering, which is, do MCEDs work with cancers such as kidney that don't shed a lot, right? So the biology of this test is literally taking advantage of whether or not tumor cells are shedding their cell-free DNA into the blood. And so certain cancers, by definition of how they're encapsulated or where they're located, are not going to shed a lot of cell-free tumor DNA into the blood at early stages, right? And so those are going to have lower sensitivities. If you actually go to the website for the one available test to order, you can actually look up the specific sensitivities of each cancer, as opposed to the aggregate statistics that we shared tonight across the entire screening test. I do think it's really interesting, though, that I believe confidently that in the future we will see multi-cancer early detection screening on urine to leverage the same technology, but at a part of the body where that cell-free DNA is more likely to be shed in the genital urinary tract. So things to come.
So I'll just take a couple. There's a couple questions just asking about clarification on the cost. So it's $949 for the Gallery test. And then intriguingly, a couple questions both on the possibility of overdiagnosis. Are we going to, and they both cited PSA testing and prostate cancer, which we know has been an issue with PSA screening for prostate cancer, especially among older men with multiple comorbidities. It really wouldn't necessarily make that much of a difference in terms of their morbidity or mortality. Overdiagnosis is a possibility, and this is something that we're going to need to continue to research because while I always think of ovarian cancer and pancreatic cancers and upper GI cancers as fairly aggressive, promoting a lot of that morbidity and mortality. There might be forms that we discover that actually are a little bit more benign and don't have such an aggressive course. I doubt it, but this is possible. So I think it's something that we have to be mindful of, but I don't know if there's really a lot of data right now on overdiagnosis. The MCEDs do increase in sensitivity, though, I think it was the DETECT-A trial, with increasing stage of the cancer, which makes sense. There's more of a tumor load, and therefore they're putting more cell-free DNA and biomarkers into the bloodstream. So yeah, more to come on that. But a really good thought in it, and something I think that those who are leading the research in this community are very aware of, is the possibility of overdiagnosis. Anybody else want to go?
Sure, yeah. So I'm going to combine these two because they're kind of, at least my answer will be related. So the first one says, what about melanoma detection? And the second one said, have the 3 presenters today, if over age 50, I think that's probably fair to say, had MCED testing done. So I took this one, or it was handed to me because I do share that I actually had melanoma 5 years ago. So I have done Gallery testing because I do live with that fear of recurrence and that it will be metastatic when it recurs. And I have 3 amazing children, and I don't want that to happen. So currently, the only follow-up I get every year for melanoma is an annual chest X-ray offered to me and some regular blood labs. So I feel like by the time cancer shows up there, it's going to be too late. I want to catch it the second it starts recurring or metastasizing. So yes, I have done the testing, and I've chosen to do it annually.
Both my wife have no cancer history, and we both have had the test, and we're both doing it biannually.
Nope. All right. All right. Oops. So if a patient has known HPV positive, so they had cervical cancer screening, HPV came back positive, is it worth it even to do the test? Again, shared decision making. I think that was a really good point by Richard. I think he made that that's one of the things that can throw the test off, but it doesn't mean it won't still be accurate. And so therefore, it's something we can discuss. And remember that most patients actually, clear HPV when it's found on their cervical exam. So therefore, if it was, especially if it was like 6 or 8 months ago, they very well may be HPV free at the time of screening.
Does Quest Lab run this test? No, this is a specific test. The one that's out is a specific test done by Grail. It has to be sent directly to them. Will insurance pay for the additional tests? We answered that already. Currently, I've not had any pushback.
That's a good one.
So where I practice in Utah, Intermountain is the big insurer and hospital organization, and they're covering it. And then the sidelight one, which is less common, is Blue Cross, and Blue Cross doesn't cover it. But a lot of people have heard their friends and neighbors have it, so they're asking me for it. So in the right group, I've been doing it. I have had 2 positives there, and Blue Cross did cover it. So my experience is they'll cover it after the fact. They won't cover the test, but they'll cover the workup after the fact. That's my experience. I can't talk about all insurances or exactly where it would go, but it sounds like that's pretty much the case. And then the diagnostic code, we're just using physical codes on it, but that's maybe just what Intermountain has picked and said as long as you put that down, they're covering it. Otherwise, it really doesn't matter what code because most insurances aren't covering it.
This is an interesting one. It says, do you recommend that patients enroll in long-term care insurance and life insurance before being tested? So I think the person who wrote this is connecting the idea of pretest counseling to hereditary genetic cancer screening. In which case, yeah, part of the pretest counseling is that we do want to advise that they have life insurance and long-term care insurance in place because once that positive gene test results, that could become impossible to obtain. However, I would think of this more like routine cancer screening, right? Like mammography or low-dose CT scans and colonoscopy, and we don't routinely tell our patients to go get life insurance and long-term care insurance before we order those screening tests. So I would put it more in that category instead.
So I've got a couple questions, really excellent, coming in about false positive results. So you have the cancer signal detected. There is a site of origin. You do the appropriate workup. You do it thoroughly. Maybe get a consultant in, because there's nothing there. They can't find any cancer. What's the next step? Do you do a whole body CT? Do you repeat the MCED? What do you do? Could it just be that it's such an early cancer you can't detect it on say an endoscopy? Yeah, that's a great question. I would think about repeating the MCED might be a good procedure in that case. In some of the clinical research of MCEDs, that was actually part of the protocol. If you got a positive result, it automatically went for a verification of the positive result. Any thoughts?
Well, and that's free, right, to have that one repeat test?
Yep.
Yeah.
Yeah, Gallery will pay for a repeat. If you have a positive, you work it up, it's a negative workup, Gallery will pay the second one.
But you wouldn't recommend that if you get a positive with a cancer signal detected, not just to automatically repeat it?
Oh, no.
Because that's
No,
right.
no.
So
Well,
I
do the
wouldn't
workup
either.
first.
You start the workup first and then go. And that would take it a little bit further. So for our ovarian cancer example, if your physical exam, your ultrasound are negative, get the MRI too, and get the CA-125, and have gynecology see them, and then if there's still nothing, then think about repeat.
So this one is a question more about the technology and what is the use of cell-free DNA after being treated for a primary cancer. And so this is getting at a different aspect of this biology. We're leveraging that cell-free DNA for screening, but in the oncology space, they are starting to leverage cell-free DNA for minimal residual disease monitoring post-treatment. And with that, you can actually have a test that's looking at that specific type of cancer, which means you can have a much higher sensitivity, right? Because you already know the patient had that cancer. So, so you can actually follow post-treatment, and this is happening in the research space and starting to eke into the clinical space in the oncology side of things, and it's very, very interesting.
I'll add to that one just a little bit because I had a question here. What about a patient with 3 or more different cancers? Will MCED find them all? Probably, but just so you know, in Pathfinder, the one double-blind study out there, a preclusive was that if you had cancer in the last 3 years, you were not eligible to be in the study because there's background noise that might pick it up again while you don't actually have cancer. And we're moving towards the idea of maybe even using this to monitor how the cancer is being treated. I mean, but we're talking about future stuff here. I mean, what we know is what we know up till now, and we don't know anything further. And the only study out there that's prospective said if you had cancer within the last 3 years, do not run this test.
The only answer or question that these are great questions, by the way. Thank you very much. There's one that is a little different. So, who owns the patient's DNA? Who owns that sample after it's run? What happens to it? Do you guys have insight on that?
Goes in the garbage.
Yeah, that's my understanding. But I just didn't want to make sure. So yeah, I don't think it's. They are using machine learning, though, to continue to calibrate the process, which is something that's kind of exciting because usually we think, well, you have this test, it's a laboratory-based test, it's going to be fairly static. But in this case, we actually should see a greater equilibration between that sensitivity and specificity. Yeah. There's a question right here. Do you want to? Oh, cool. Are you using a card? So I'm going to start to close things up because you guys have been troopers and it's awesome. We'll try to get to your question here in a second, but just a couple things to say. Oh, okay. Oh no, not that. God no. Oh. I thought there was a thank you slide. Maybe this is. So yeah, there's coming soon. Don't. It's just it's embarrassing. All right. Okay. I guess we're just going back to question and answer. Do we have one more? You want to take it, Richard? And then we'll close.
Can you use these tests for diagnosis in symptomatic patients? Simplify. I tell anybody who put this one out, go read Simplify. It's the first study out on using this test using Gallery for diagnosis. I've read it myself. It's relatively new. It certainly can be used for diagnosis. These are very early days for that. But if that's your question, go read that study, Simplify.
All right, with that, thank you all again for attending. Thanks to those online as well. Hopefully you found this interesting and relevant to your practice. Take care and have a great rest of your meeting. Hey, man. Stephen, thanks.